Welcome to another episode of Reboot with Dr. Arsi Marin. I have Dr. Alyssa Conklin out here with me today. And Alyssa is going to talk about a very important, very common topic which affects a lot of women, and they don't even know that it is out there and they could be affected by it. And that is iron deficiency anemia. Before we deep dive into the topic, I would love for you, Alyssa, to introduce yourself. Tell me about your journey. What got you into this space?
Sure. Thank you for the intro and for having me here in your space today. I'm an assistant professor in general obstetrics and gynecology at Indiana University. Here in my space at Indiana University, I'm also the director of the generalist division, the medical director of the Coleman Clinic inside University Hospital, which is a general OBGYN clinic, the medical director of our IUHP midwifery group, and I do statewide work through something called the Indiana Perinatal Quality Improvement Collaborative, abbreviated IPQUIC, which is a statewide collaborative aimed at reducing maternal morbidity mortality. Through that, we have multiple subcommittees, and I co-chair a subcommittee on trauma-informed care, which is one of my professional passions. Mm-hmm. I'm also a subject matter expert in trauma-informed care through the Midwest Trauma-Informed Training Center. I've been practicing trauma-informed care for more than 10 years. And one of my professional focuses and research focuses is on decreasing healthcare disparities, which is how I got involved in creating an anemia protocol that we now use throughout the state of Indiana.
That's pretty impressive. I mean, iron deficiency anemia is so common, but why is it so common?
Well, it's common for a lot of reasons, in particular with women. There's a number of factors involved. One of them is dietary intake. So the average American diet, at least on my side of the planet, is not the healthiest. So a lot of fried foods, fatty foods, processed foods, unhealthy foods don't have a lot of iron in them. So dietary intake is one of them. Chronic blood loss for women is also another, which is very common, and heavy periods. And if you combine those things, so people have maybe a chronic lower intake of iron orally and heavy periods over a long period of time, can significantly deplete the iron stores. And when you add on to that any pregnancies, especially if you've had many pregnancies, that's a significant also cause of losing your iron stores. And then there's other things that are less common but still very important, like malabsorption. So people who have had gastric bypass surgery or who have inflammatory bowel diseases like ulcerative colitis or Crohn's disease can have a difficult time in absorbing the iron from their dietary sources. And so they can have lower iron stores for that reason. And then there's a number of chronic diseases that also cause iron deficiency.
You know, I just realized we jumped straight into iron deficiency anemia, but did not actually define what is anemia and how it is different from iron deficiency is different from other causes of anemia.
Anemia itself is just defined as having like a hemoglobin below 12. Iron deficiency is when your iron stores and your ferritin level are low. And so in pregnant patients, that's not true. So ACOG, the American College of OBGYN, defines anemia as under 11 in the first or third trimester and under 10.5 in the second trimester. So that's the blanket diagnosis of anemia. And there are other causes of anemia. You can have folate deficiencies and vitamin B12 deficiencies and other types of vitamin deficiencies that can lead to anemia.
So can we kind of go beneath the surface of, just not low hemoglobin is anemia, but iron deficiency anemia? Why is, iron important for the human body? Can we talk about that?
Yeah. You need iron in order to build your red blood cells and to carry oxygen. And so iron is incredibly important to our bodies, which is why a lot of the side effects related to iron deficiency, feel so bad, like fatigue and weakness, where your skin can actually get pale. You can lose that coloring, which we get from having iron and extra red blood cells and things of that nature.
The symptoms you're telling me, fatigue, just being tired and pale skin, people might just think they didn't get enough sun and it's not truly, they're not sick or anything. Like, how do they even know that they are struggling with anemia? What would be some warning signs?
So some of the warning signs are feeling that way. If anybody has heavier periods, which if you don't speak to other women or to your physician about your periods, you may not actually even know that your periods are heavy. because there's a very objective definition of that, and then there's subjective definitions of that. And so, being able to be open with someone, either other women in your lives or with your provider, is very important to discuss that. But having heavy periods and, a decreased oral intake and things of that nature can lead to that iron deficiency. And then this is a slow symptom problem. It's not something where you just wake up one day and all of a sudden you have every symptom under the sun for iron deficiency, which goes beyond that pale skin and that feeling of fatigue. I mean, people can get something called pica, where they eat non-food items like cornstarch. I've seen cat litter, dirt, sponges, chalk, things of that nature. But also the most common form of pica is just a strong desire to constantly crunch on ice. So, any of those kind of things are important to note, especially if someone points it out to you and says, gosh, you eat ice all the time. Mm-hmm. That might be a sign that, hey, I should have a chat with someone. People can get restless leg syndrome at night related to iron deficiency, and resolving their iron deficiency can actually resolve that problem. And even brittle nails and hair. So I've had patients with iron deficiency, non-pregnant patients actually have hair loss. And as part of that was their only complaint. And as part of their workup, we found that they were actually iron deficient. So a lot of that kind of stuff can happen.
So, let's go back to the first thing you said, heavy periods. Can you define what a heavy period would be?
Yeah, objectively, it's 80 milliliters in a period, which is, nice and easy to measure when you have a menstrual cup, but difficult to measure when you have pads and tampons. And so, subjectively, most of us who care for women with periods get used to listening to their descriptions with regards to how often they're soaking pads and things of that nature, which is why I encourage women to say these things to their provider.
So, most of the population, is it the number of days they are bleeding or the number of times they're changing the pads in a day? How would they quantify whether they're a heavy bleeder or not?
Yeah, soaking more than 2 pads in an hour and 2 hours is very heavy. Most people don't soak their pads. And so it's, I have conversations with them about what I mean is most people will change their pads before they're soaked because for hygiene reasons. But if people are bleeding through their products in the middle of the night, if they're having to wear, the very large pads at night and the Super Plus tampons, and they're still having to change them multiple times in the night, that's a big red flag that your periods are heavier than they should be.
That's very interesting because, when you go to the pharmacy, you just see the super absorbent and hyper super absorbent material. So it could lead to, could that lead to a delay in diagnosis itself?
Yeah, probably. But again, I think it really boils down to we don't emphasize in our culture enough of women speaking about these things, right? This is something you just deal with in private. And I think the more that women either talk to each other so they can compare what their periods are like, or the more that they disclose to their provider about their periods, the more likely these things will be caught in advance.
So do you see this, most of the time in your practice in pregnant women or in teenagers? Where does the spectrum lie in?
The bulk of my iron deficiency or just anemia management is in pregnant women, but I have many, many, many non-pregnant women who have lived with chronic heavy periods for a long period of time. And, I'm relatively aggressive about diagnosing and managing anemia. And so I will draw those iron panels, that ferritin level, that vitamin B12 level, and then treat accordingly. And so I have many non-pregnant patients that I send for IV iron because their iron levels are so bad and they're telling me how tired they are. And I think, geez, they're going to have to spend 6 to 12 months of taking this oral iron to fix that problem. And many of those women walk out of the infusion center feeling better. So I would say, like I said, I take care of a significant portion of obstetric patients in my panel. So the vast majority of my anemia are therefore pregnant patients, but I have plenty of GYN patients who see me for heavy periods who also have iron deficiency.
In a pregnant patient, let's kind of go with the pregnant patient. Do they become anemic during pregnancy, or do they start, or are you how frequently are you monitoring it?
Most do not start anemic, with exceptions. So people who have a poor dietary intake, who have short intervals between pregnancies, might not have had an opportunity for their body to restore their iron stores. But the vast majority of them do not begin anemic, they become anemic. And that's just because of the changes that happen in pregnancy. So, when a person is pregnant, their red blood cell level has to increase rapidly, expanding the plasma volume by like 40 to 50%. And the red blood cell mass itself expands by like 15 to 25%, which is equivalent to like a non-pregnant person has about 2.3 grams of total body iron in their body. And when they're pregnant, the pregnancy itself requires an additional gram of iron. And so a non-pregnant person might not require any additional help in that regard and might be able to sort of skate by with even a low level of iron stores because their body will continue to make more. But if you're living on a lowish level anyway, and then you add the pregnancy to it, the demand is just too high to keep up.
It's almost like a demand supply problem when your demand is becoming high and you're not eating enough. And so, does it affect the baby when the mother is iron deficient, or is just the mother struggling? Because we've always heard the baby is going to get whatever it wants, uh, despite the mother suffering.
In the vast majority of cases, that's true. The rare exception to that is severe anemia in the pregnant person. Then it can cause growth restriction and things of that nature in the fetus. But the vast majority of the time that's exactly correct. The fetus is a parasite, if you will, and will suck what is needed out of the maternal body to the maternal detriment.
Well, as mom of teenagers, I think they suck what they need even after they are out of your
Accurate.
So, let's move a little bit to the non-pregnant women, because I feel at least pregnancy, women are going to the physicians and taking care of themselves a little bit more. There are non-pregnant women who may not reach out to primary care doctor or even get a yearly OBGYN checkup. So what can you tell them? Like, what should they be cognizant about?
Well, like we mentioned earlier, just, their periods is the primary source, at least in my world as a gynecologist, for patients who have anemia of any kind is just prolonged menstrual blood loss. So knowing when your periods are normal and not normal is very important. Having a conversation with your provider about that, having your blood checked relatively regularly if you do have really heavy periods, and then addressing it as aggressively as possible, either with dietary intake or prescription supplementation is important.
So let's move on to the treatment phase of iron deficiency anemia. Is just you mentioned IV iron, but I want before you go into an injection and an infusion, is increasing dietary intake the first step?
Yeah, well, first step, it depends on where we're starting, right? So if we have a normal hemoglobin and a slightly low iron or ferritin level, we can work with that potentially. And so then, yes, I would recommend dietary changes. I print out, handouts that describe iron-rich foods. They're easily accessible online. They include things like lean red meat, and lean means less than 10% fat. And then that can be, beef, lamb, pork, things like that. And then poultry like chicken, seafood, beans, lentils, dark leafy greens. And, that seems like a very esoteric statement. What that really means is things like kale and spinach and collard greens, even romaine lettuce would count. So including that regularly. And this is not something to say, well, I have that once a month. No, this is something that you would need to incorporate in a very regular portion of your diet. And then dried fruits help. Eggs have a decent amount of iron in them. And then there are iron fortified or iron rich cereals that are beneficial as well.
When do you go from just measuring like your hemoglobin level, which is a complete blood count, you get the hemoglobin level, to checking ferritin levels and B12 levels?
Well, in the non-pregnant patient, when people have either subjectively or objectively, described to me that their periods are definitely heavy, I would start out right off the bat getting a CBC and at least a ferritin. So I would be checking their hemoglobin level and I'd be checking their ferritin. I often will add iron profile to that and vitamin B12 because you'd be surprised how many people would have what's called microcytic hypochromic anemia, which in theory would only be iron deficiency or lead, and actually have vitamin B12 deficiency, which should be a macrocytic anemia. So many. So I draw vitamin B12 levels with them as well.
No, I just wanted to kind of explain a little bit about microcytic anemia and macrocytic anemia. So you're basically talking about the size of a red blood cell under a microscope. Normally 7 to 10 microns is the diameter, but if it's way smaller, you call it microcytic, and it's enlarged, like in a vitamin B12 deficiency, where the cell has just enlarged to overwork, is the macrocytic anemia. Anything you want to add to that?
No, you're correct. And we see those parameters because obviously most of us physicians are not the ones looking under the microscope, but we see those numbers. And in general, we're all taught that certain types of anemia have certain causes, but they often coexist. So I've learned that, and so I do the iron profile, and I do vitamin B12, and I do what we call CBC to check the hemoglobin in patients who come to me who are non-pregnant, who are complaining of very heavy periods and at least one symptom of anemia, fatigue, pica, things of that nature. I will just draw that off the bat. If I get a CBC alone and I'm looking at their hemoglobin and it's below 11, I would typically then also get the iron profile and all the things if I hadn't already done that.
So you talked about iron-rich foods, okay? But what if you really have a very picky patient and they just, how about oral supplementation? Do patients like the, taking iron pills?
Mhm. I think it's well tolerated for most people, but there are certainly side effects that for some people they just can't tolerate. Most of the side effects related to oral iron are GI related, so feeling nausea, having vomit, nausea and vomiting, feeling more gassy, constipation. Some even complain of diarrhea, but I would say the vast majority of patients who I see who have side effects, it's really constipation related. So some people just truly can't tolerate it, and also in order for the oral iron to be absorbed the most efficiently, how you take it matters. So, if you're a pregnant person, you're taking a prenatal vitamin, you don't want to take it with your prenatal vitamin. It's ideally taken in an acidic environment. So you don't want to take it around antacids of any kind, Tums, or, the brand drugs that you can buy in the pharmacy. And you ideally on a fasting stomach because there's more acid in your stomach during that time. And some people can't tolerate that, for example, on a fasting stomach because it makes them nauseous. And so it's a balance of trying to maximize the absorption and minimize the side effects.
There's always this, I've seen vitamin C, which is kind of combined with iron for better absorption. Uh, what's your take on that?
Well, historically we were taught that you should take vitamin C with it, or take your oral iron pills with orange juice or things of that nature. But the literature hasn't really borne out that that's true anymore. It certainly doesn't hurt. So if for example, you can't take your oral iron fasting, the next step is like a glass of orange juice. Certainly is not going to hurt, and is better than, for example, having a full breakfast with your oral iron.
So if we are going to just depend on, let's say there's someone's on a vegetarian diet and they are just depending on green leafy vegetables or, plant-based sources, how does that compare with the meat sources?
Well, the leafy vegetables contain non-heme iron, which is less efficiently absorbed by the body than heme-based iron, which is what comes from meats. It doesn't mean you must have the meat-based heme iron. You certainly don't have to. But that's, in that case, if I have someone who says, hey, I want to really make an effort forward with my dietary changes, I'm going to focus more on my green leafy vegetables, my lentils, my beans, and things of that nature. I don't think that's unreasonable. And then I just recommend having a follow-up to assess how they're doing with that. And if they're not getting to where we need them to be, then I would typically recommend after that, if they're not going to choose the meat-based iron sources, that we move on with oral. Because, for example, spinach has about 2.7 milligrams of iron per 100 grams versus an oral iron tablet like ferrous sulfate has 65 milligrams of elemental iron in a 325 milligram tablet. So you're certainly getting a lot more of that elemental iron in an oral tablet than you would in spinach, for example.
So, when do you move to infusions then?
Typically, what I recommend is we're going to do some sort of intervention. If we're doing diet-based first, then we try that for a month or two and we reassess the levels. If that's not cutting the mustard, then I recommend moving on to oral. And I typically recommend assessing those blood levels about 4 weeks after they've started it, assuming they're tolerating it and they're taking it as instructed and things of that nature. And if we're not getting anywhere or worsening, which is more common among the obstetric population, then I recommend moving on to IV. That's true no matter what for me, no matter what their hemoglobin level is. So if their hemoglobin is like 10.5 or 11, I mean, technically in pregnancy, below 11 is anemic. But if their hemoglobin is 11, but their iron is very bad, and they've already tried the oral iron and they feel very bad, that to me is a very reasonable choice to choose the IV iron.
So it's very interesting just because, as a cardiologist, I also follow hemoglobin because when the hemoglobin is less than 10, we really start thinking about is there enough iron levels and should we give, given iron infusion as an inpatient also to avoid blood transfusions because we don't like to give blood transfusions unless we have to. So we use IV iron as a surrogate. And as you said, I've been really surprised that by the completion of 3 days, patients feel so much better, and especially my kidney patients too.
It's really true. I mean, if their iron stores are very poor, I've gotten to the point where I feel pretty comfortable telling them they're going to feel well walking out of the building. The analogy that I use to describe the comparison of oral iron to IV iron is like, pretend you go to a gas station and your gas tank is nearly empty and you have a spray bottle of gas. Now you can sit there and spray that gas tank with a spray bottle you'll eventually fill up that tank, but it will take quite some time.
Mm-hmm.
That is oral iron, right? You'll get there eventually, but it'll take months. The IV iron is like using the gas pump and filling up your tank. It takes minutes, So for people in the relative scheme of things, there are some
Yes.
iron infusions that take 4 hours, but it's a one-time dose. There are others that are weekly, but they're relatively quick. But you have to do them 5 or 6 times, depending on the type of iron that the insurance prefers or that we have on formulary in various institutions. But that's the analogy. Is like you can get there eventually with oral iron as long as you don't have a continuous loss, like heavy periods or pregnancy. But sometimes it's just not enough, and you've got to go to the IV iron.
So, since you have experience implementing a statewide program, do children get screened for iron deficiency in middle school or high school?
I'm not a pediatrician, so I can't actually comment on what children do and what their screening happens in children.
That's absolutely true. So I should have reframed it in the sense, do pediatricians send them to you, or does the mom bring the patients to you? How do you?
Typically, they come to me again as a gynecologist, so I see young teenagers with really heavy periods. They'll come.
Okay.
So I've diagnosed von Willebrand's a number of times in patients, and certainly have treated their heavy periods and managed their iron deficiency. I can't recall in 17 years if I have ever sent a teenager for IV iron, though.
Okay.
I think we've gotten, once we stop the outflow of their periods, their iron stores can replace pretty significantly. And one story I have is a young teenager who I first met when she had a hemoglobin of 1.6, and she walked into the ER saying, "I just can't keep up with my fellow classmates anymore in gym class." And of course, no one believed that her hemoglobin was really 1.6, so it was repeated, and it sure enough was. And so she got obviously like a massive transfusion protocol and was found to have von Willebrand's and obviously very terrible menorrhagia. And once that was all controlled, very quickly, her hemoglobin became 11.5 within 6 weeks.
So what is the role of oral contraceptive pills in the treatment of iron deficiency anemia and menorrhagia? Menorrhagia is basically heavy periods.
Right? Yeah, so it's not just pills. Any form of contraception hormonally that can suppress ovulation and therefore your periods or decrease the blood loss during your periods will help, decrease that loss of the iron. So if you bleed less, your body has more chance to fill up its iron stores each month. So when I have patients that have pretty significant menorrhagia, meaning pretty significant heavy periods, and or we've gotten to the point where they've needed IV iron, I typically recommend completely suppressing their periods at least for a few months while we fill their iron stores back up, either by IV iron or oral iron.
Fantastic. So I want to talk about strange things which I've seen on the internet. Let's just ask you: liver, chicken liver, beef liver, bone marrow. Are those good sources of iron and should be? I've seen people taking liver pills and bone marrow pills, etc. What is your thought on those?
I mean, the truth is, statistically speaking, they're not going to raise your hemoglobin or your iron levels any more than the normal heme-based, meat-based iron sources. So if you want to take those things or those supplements, it's totally okay to do that. But if you also just want to eat a steak, that's okay too.
I think your iron deficiency anemia patients are probably getting the highest recommendation for eating steaks more than any other disease patients, I guess.
Yeah, probably. Lean steaks, though.
Okay, yes. I mean, so I want to kind of quantify what you mean by heme-based protein. So basically, steak or any red meat is red because of the heme protein, which is giving that red color. And that's basically from the ferritin level in the steak itself.
Yeah, that's right. So it's essentially, if you will, use the term more bioidentical to our bodies. So it's what we make, it's what we're used to, and it's more accessible to us through our digestive system than non-heme-based iron.
Fantastic. So, you told us one success story where you diagnosed von Willebrand's disease. Do you have any other story of a patient whose presentation or the situation completely took you by surprise and it ended really well?
Only that one. I have many that are not as aggressive as that one. But now that we've implemented that protocol for our pregnant patients, and like I said, I'm also pretty aggressive about managing anemia in my non-pregnant patients. In general, the stories turn out well once they're diagnosed. But I've had many patients come to me, for example, GYN patients where they've been managed by other providers with nothing except oral iron, and they continue to have their very heavy periods. and nothing's really being done about that. And their hemoglobins are just limping along at 8 or 9, and their iron levels are not changing, of course, because they have this chronic loss. Those patients, you really gotta stop that. You gotta stop the outflow and increase the intake in whatever capacity that is between you and the patient. So I've seen a number of those patients, and when they come to me, those are patients I typically will suppress their periods, if they're willing, obviously with shared decision making, and give them that IV iron to really reboost up those stores. And those are usually the patients that walk out feeling like so much better. I've had patients send me messages through their chart many times saying, I cannot believe I've been living like this for so long.
Absolutely. So talk to me about your task force and your protocol itself, if you can summarize that.
Sure. You mean on the anemia protocol?
Mm-hmm.
So in pregnancy, what we did in our system, so this is for the entire IU Health system in the state of Indiana, we changed our order sets to include ferritin for every new OB lab. So in our country, we have, when they first present to care, there's a set of labs that are drawn. And then typically some labs are drawn again as they enter the third trimester when we screen for gestational diabetes. So what we did was we changed the protocol to include ferritin. We have a protocol written where if their ferritin level is below 30, even if the hemoglobin is normal and they are pregnant, we recommend supplementing with oral iron. And we have a protocol written for that, so it's easy to see those recommendations and how to order the necessary oral iron supplementation and subsequent labs. We typically then recommend rechecking labs 4 weeks later, or if that happens to be close to their third trimester draw, then we would just wait until then. We redraw that ferritin level, and at that point can add the iron profile and the vitamin B12 levels if indicated, meaning if their hemoglobin was low or their ferritin was quite low, I would add the iron profile and the vitamin B12 levels. And then we have protocols on when we should then move on from the oral iron to the IV iron. And then assuming they're well managed up until that point, at 34 weeks, we now recommend a separate blood draw for all patients to also assess for anemia. So we do a CBC and a ferritin level at that point as well, and more tests if indicated. So if they were already anemic and we've already been managing them on that oral iron, we'll add the additional iron profile and or the vitamin B12 level if it hasn't been checked yet at 34 weeks. And then we're pretty aggressive about it. And so after they get their IV iron dose in our institution, our number one, we have an order of IV iron that we recommend. The first one is IV dextran, because it's a one-time dose, which is the really convenient part about it. But it's a 4-hour infusion. And so patients have to be willing to sit in that infusion chair for 4 hours to get that done. And most are willing. Most are grateful to have it. And either they can't tolerate the oral iron or it's not cutting the mustard. And then we also have protocols in place for who needs pretreatment before IV iron, because there are some patients who are at higher risk of having an allergic reaction to IV iron. And so all of this is built into the order set, so no one has to memorize any of it. If they just type in the word anemia into our electronic health record orders, this entire order set pops up.
That is fantastic. I mean, I cannot imagine how you have made this process efficient, and patients can get their care very quickly and very rapidly and thoroughly. It seems like a very well thought out thing. Kudos to that. I'm sure you're helping so many women just with the kind of formalizing this entire process.
Our main goal is to decrease one of our metrics that we monitor, which is severe maternal morbidity related to blood transfusions. Mm-hmm. And so this protocol that we built went live in October. And so once we get to, let's say, August or September, and all of our pregnant patients who have delivered have gone through their entire prenatal care with this protocol, then we'll be able to analyze the data and see if it made a difference. And it's my goal to see if this sort of management protocol can actually be sort of published as best practice and moved nationwide.
See, now you've just given yourself a second invitation to come back later this year and update us about how the results of your protocol.
Be happy to do it.
So, if you want to give one parting message to my listeners, whether they are men or women, what would that be?
Well, with regards to anemia, in particular to women, it would be to, at least have a conversation with your provider about what your periods are like, because you may be living with heavy periods your whole life, and to you, this is normal. So my recommendations is to at least just tell your doctor, this is what my periods are like. Is this normal? And if they say yes, okay, great. You've asked the question. But if they say no, that might open up a door to a whole bunch of things that can change your life. And so it's important, I think, to have that assessed. And if you are anyone who has a chronic illness of any kind, you should have that conversation with your provider as well, because many chronic diseases can cause iron deficiency. So I would recommend having that evaluated as well.
So, Dr. Conklin, I enjoy this conversation. I think what I am getting the most about is the power of the sisterhood, that women should talk to other women about things which are comfortable and uncomfortable and have that open relationship, and only then we can rise up together.
100% agree with that.
Well, with that, thank you so much for your time. I truly appreciate everything you've done, and I hope your protocol is successful and you can come back to us later this year and tell us, share the results of it as well.
Thank you very much for having me. It's been a pleasure.
Yes. With that, we come to another episode of Reboot with Dr. R.C. Marin. I hope you enjoyed the show. And if you liked or you know someone who might be struggling, please do feel free to share with them. Also, rate and review us so that more people can find us online. With that, see you later. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.